So I'll be taking the next talk. That's on the science of pediatric biometry, which is Ayani. Yeah. So I'll be talking about how to do and what all challenges we faced while doing pediatric biometries. So obviously, although we are dealing with child, but it's not as simple as playing with a child. So despite the dramatic differences and revolution which has taken place in the field of adult cataract surgery, the field of pediatric cataract surgery is still lagging behind in terms of especially the IL power calculations. So why is it different from that of an adult? Because we are choosing an optimal IL power for a child eye which is still growing. So we are implanting a fixed power into a growing eye. That's the biggest problem, biggest challenge which we have. Younger the child, more difficult is a problem. And we are remember, we are using formulas which have all been designed based on calculations being done for the adult eyes, not for the pediatric eyes. Besides this, the formula issues which I've talked about is one important issue, the choice of the IOLs, the measurement issues, which is very, very difficult. In younger the child, more is a problem. The formula issues I've already talked about, and the third major issue which is there is the growth of the eye, which is taking place with time, or the myopic shift, along with the visual axis opacification, which is another thing. So what is the target refraction which you are supposed to target is again very, very difficult to decide. So now, if you look at this chart, we know that there's a normal curve of how the eye grows. At birth, your axial length is around 16 to 17 millimeters, and there is a rapid growth occurring during the first three months, and thereafter it gradually grows till about the age of almost 18 months to 2 years, and then the growth is very, very slow. For the keratometry, there is a marked variation which is occurring from 51 to 43, flattening occurring during the first 18 months. For the lens power, marked decrease occurring in the first year of the life of almost 10 diopters, a change in the lens power because of the change in the curvature of the lens. So all these changes, as I said, are markedly occurring usually during the first 2 years of life, 1.5 to 2 years of life. So the maximum amount of myopic shift, as seen in various studies, is again in the same duration, same time duration. So as I've already listed, let's look at the factors which affect this myopic shift. The normal eye growth pattern for everybody, the age at what time we have operated the child for his cataract, whether we have placed the IOL or not, whether it was a unilateral or bilateral cataract, the genetic influence which comes from the parents, and the visual input, whether for how much time period that eye was deprived of not seeing clearly. Besides this, the other issues are, as I said, they have a different anatomy. They are not the same as adult eye. They have a shorter axial length generally, a steeper cornea with a higher keratometry readings, and a deeper and a smaller AC. So the standard IL power formula which we are using for the adult's eye are inadequate. This is because obviously in these cases we are doing ultrasonic measurements, and the ultrasound velocity from different components is different. We all know that. Second issue is the growing eye, which I've already talked about. So the parameters are changing as the growth is occurring. Then the third issue is the measurements in the office settings. Obviously, for most of the children, we are not able to do in office settings. And we are usually using our manual instruments, manual refractometers or handheld autorefractometers. Otherwise, we'll have to take them under anesthesia because of the measurement issues in the OPDs. So in the anesthesia, obviously your orientation is not straight. Your eye may not be looking exactly straight. So you'll have errors in measurement arising because of that. Then you're using again ultrasonic measurements. Best would be to use immersion, but still with that also there are chances. If you're not able to use immersion for some reasons, then obviously you will have more chances of compression. And remember, these children have a lower ocular rigidity, so the effect of compression is much more impact of compression as compared to an adult eye, which will be around 2.5. Here the compression is 3.75 diopters per millimeter. Look, go back to your formula which I talked about, 2.5 millimeter into keratometry, into axial length. Here it is 3.7 diopter per millimeter of axial length difference. This I've already talked about. So lack of fixation within when you're doing measurements in anesthesias, and also the accuracy of the handheld keratometers for the cylindrical measurements. It's not very accurate. Then the problem of non-availability of all these handheld instruments with every surgeon. Also, infants have a different steeper keratometry. As they grow older, their keratometry lessens down, the steepness reduces. Girls have steeper keratometry. And also it has been seen by studies that bilateral cataracts tend to have more steeper keratometry readings as compared to unilateral cataracts in children. So the errors of excellent measurement I've already talked about. Applanation obviously will cause more errors as compared to immersion. Immersion scan would be recommended if you are using ultrasonic. But the best, as I said, because the velocity of ultrasound is going to vary, so the best is to use the scarf method, measure in the aphakic mode, where you're using the velocity of sound as aphakic mode of 1532 millimeters per second, and then add 0.32 millimeter to the exit length to get the actual exit length or the corrected exit length factor, as we call it. Optical biometry, wherever you can do that. Obviously, this is more accurate. And the effect of cyclopegia also has to be considered. Don't dilate before doing your optical biometry, which again, Justine would cover up. So I'm not going into details of this because it causes changes in the things. IL power calculation issues also I've talked about. So obviously, these are derived from adult data. And remember, obviously, these are smaller eyes, so the actual IL power which will be calculating will be higher. It requires more actual exact exit positioning or more exact ELP determination in these cases, which we are not able to determine. So as a result, we have less predictable IL positioning in these cases, leading to, because of the various factors which I've already listed earlier, as greater vitreous pressure, steeper corneas, capsular contraction, which is again very commonly happening post-operative in these cases, and the unpredictability of all the formulas, all the various formulas, and more the variability, younger the child. As an pediatric cataract surgeon, I would always still prefer to hit the target. So the desired goal to hit the target would be according to the age of the child is to undercorrect. Higher the IL power, more will be the undercorrection. Bilateral cataracts, more than target for more undercorrection. Unilateral cataracts, you need to create a balance between the two eyes. You want to minimize the anisometropia. If the normal eye again has a significant refractive error, then probably again balance for the refractive error of the other eye. If the amblyopia is dense, then again aim for a lesser hypermetropia, because the compliance with the amblyopia therapy will be poor with the high refractive error left as a residual refractive error. If poor compliance, again leave with a lesser refractive error, try to emmetropize the child in these cases. So what I do in my practice is for unilateral cataracts between 2 to 4 years, normally I take a calculation of spherical equivalent of the fellow eye, minus 1.25. More than 4 years, I usually make it as equivalent to the fellow eye. For infants with bilateral cataracts, less than 6 months, now I started implanting IOLs even at 4 months. Earlier I was doing it after 6 months, but now at 4 months I've seen it's better to implant the IOL. So I'm aiming for a moderate hyperopia depending upon the other eye factors of 3 to 7 diopters. Infant aphakia treatment study also recommended the same. For 6 to 12 months, I am aiming for a milder hyperopia of roughly around less than 3 diopters. We have pediatric IOL calculators which are available, Windows-based programs which are available online. And these are general undercorrection guidelines which can be followed of percentages. It is usually lesser than 2 years, which is more controversial. For above 2 years, it's very straightforward of 10% undercorrection or even lesser as we move with age, reduce 1% per year of age. And best choice would be in the bag placement of IOLs and doing an optic capture of that. Piggybacks is a choice in some cases, especially as primary piggybagging, where you're placing one IOL in the capsular bag and one in the sulcus. And the one in the capsular bag is the actual IOL power, which will be calculating for the emmetropic without the undercorrection. And the one in the sulcus is the difference between the two, which you can remove at the appropriate age. And the type of IOLs, I'm not touching on this. This is not the part of the talk, so I'm just skipping this part. For the secondary IOL calculations, because there may be a lot of children who have been left aphakic at the time of primary surgeries, it will again totally depend upon whether you're able to place the IOL in the bag, in the sulcus, or in the anterior chamber. Remember, any power which is placed more anterior in the eye will have a greater refractive error than it will place more posterior. So your position, IOL power calculation will have to be done accordingly. Especially in these cases, if the child has been on soft contact lenses for hard contact lenses for a long time because of his aphakia, then it is important to remove the contact lenses for a longer duration, at least 2 weeks before you take the keratometry readings. And you can use these exit length or K values just by using the aphakic refraction also. So there are formulas for that. So I'm just skipping this also. The secondary IOL for piggyback IOLs, which is done as for refractive surprises arising in children, we can have these secondary piggyback IOL calculations. So in the end, I will just say, try to customize for each case, depending on the age, the laterality of the cataract, the visual acuity of the child, and the amblyopia status, the likely compliance of the child and the family, obviously the caretakers of the child, as regards to glasses, contact lenses, and the amblyopia therapies, family history, the genetics have to be taken into consideration, and also whether you are placing the IOL in the bag, in the sulcus, or in the antechamber. Remember, diligence is very, very important in these eyes because these are not just miniature adult eyes, but they are growing eyes. And careful consideration to every changing parameter in these eyes will make a big difference to your outcomes. Thank you.